This is the Best Health Podcast, brought to you by Wake Forest Baptist Health in partnership with MedCost.
Good day, everyone. Welcome back to the latest Best Health Podcast episode from Wake Forest Baptist Health. Thanks for joining us today and listening to hear what we got to say with this latest episode. Very good information. We actually have, for the first time, we have 3 guests joining us today. Plus myself helping guide the conversation. And we're going to be talking about a very important topic with substance abuse, various substances, and the abuse and treatment and resources available with our 3 special guests. Before we do that, I do want to just once again give people the general COVID-19 coronavirus website and hotline that Wake Forest Baptist Health has set up. As we do with each of the COVID-19 related podcasts. Reminder, everyone can go to wakehealth.edu/coronavirus, wakehealth.edu/coronavirus for all kinds of resources that we have available for you, from clinic updates to FAQs, all the podcasts that we've done listed there, visitor restriction information, a wealth of information for you. Also, the hotline is still manned 24/7. That's 336-70-COVID. 336-70-COVID. So I wanted to make sure people were aware of that at the beginning of this episode. Now on to my 3 really great guests that I have today. I'm very excited about getting the word out about substance abuse issues, the medical background information on substance abuse and how it can affect people, and ways, of course, to seek treatment and available resources. So hopefully someone listening out there today can take advantage of this information and pass it along to someone who they might think it can be helpful for. So we have, first of all, Dean Melton, who is the Director of Outpatient Addiction Programs here at Wake Forest Baptist Health. Welcome, sir. How are you?
Doing well, thank you.
Good. Thank you for joining us. Second, we have Dr. Heather Douglas, who's the Medical Director of the Addiction Clinic. So welcome, Dr. Douglas. How are you?
I'm doing great. Thank you. Thank you for having this podcast.
Yeah, absolutely. I know you all have been busy, so thank you for taking time to talk with us today. And last but not least, we have Dr. James Kimball, who is Associate Professor of Psychiatry and Behavioral Medicine here with Wake Forest Baptist. So thanks, Dr. Kimball. I'm glad you're joining us as well.
Yeah, I'm honored to be here. Thank you.
Absolutely. So to start things off, before we dive into some question and answer time and some really great information that you have for us, maybe just offer a quick introduction for yourselves, just to help all the listeners familiarize themselves with you all and kind of your background a little bit. So we can start off with Dean, if you wouldn't mind going first, sir.
Yeah, Dean Melton. I am a licensed clinical addiction specialist. I've been involved in doing addictions work for almost 35 years now. I've been here at Wake Forest for the past 20 as the director of the addiction programs, and that includes an intensive outpatient treatment program we do here that meets 4 nights a week. And we also have a medication-assisted therapy program. That's typically anti-craving medications and also buprenorphine. Most people know that as Suboxone. We do a clinic treating opioid use disorders. So that's what I do here, and also have some opportunities to teach occasionally.
Great. Thank you. Dr. Douglas, do you want to go next?
So I'm the medical director of our addiction clinic here at Jonestown Road. So our outpatient behavioral health is located 791 Jonestown Road. And I work right next to Dean Melton. Our offices are just 2 doors down from each other. And I'm the psychiatrist here. So I manage the medication for our patients, whether they're in the intensive outpatient program or in a weekly MAT, what we call MAT, medication assisted treatment program. There's some other things that I do as well with addiction, and as far as research and neuromodulation, in teaching and
Dr. Kimball, how about you, sir?
Yeah, so I've been here at Wake Forest since 2003, and I do a variety of things here. I primarily see patients in the inpatient hospital setting, and when it comes to addiction, I see a lot of patients there where their alcohol or other substance use disorder has affected them in a variety of ways, including a worsening of their medical conditions.
Okay, thank you all very much. Good information. Dean, I want to go first to you if you don't mind. I have a couple of questions. I'm going to start off kind of trying to frame a picture here. Just talk about a little bit about what you do day to day in helping the patients that you see. And, we can talk about substance abuse and addiction for hours and hours and hours, and we're gonna try and condense it all down into a relatively short podcast. There's books and books and articles that have been written about this. So I guess just to help frame the overall picture, maybe just give a brief overview of a little bit about what y'all do day to day there at the clinic, and how people come to find you and get assistance for substance abuse.
Sure. Well, at our location in Jonestown Road, we're entirely an outpatient clinic, and a lot of the individuals that contact us seeking care, they're either referred to us by their primary care physicians, or they're referred to us by a therapist in the community. Our program's been going for quite a while now, so a lot of our referrals just come through word of mouth. A number of our patients also come here after they may start going to 12-step meetings like Alcoholics Anonymous or Narcotics Anonymous. And so they'll contact us. And the way we do things in our clinic, we do a pretty heavy phone screening. We spend a lot of time talking to individuals about what's going on, about their level of substance use, and where they are in terms of their level of motivation and what they're seeking. And if they really indicate that they're ready to do something about their substance use disorder and oftentimes their psychiatric issues, very often our patients also suffer from depression disorders, anxiety disorders, bipolar disorder. So we do dual diagnosis type of care here very often. But we'll make an appointment and a patient will come in and we'll do a pretty extensive evaluation, a psychosocial type evaluation, looking at all their family history, their current medical history, their use history. So we go through all of that, and then if they qualify for the programs we run, we have two distinct programs: an intensive outpatient program, and people using all types of chemicals come into that program, and it's fairly extensive, and individuals come in that program 4 nights a week for at least 5 weeks. And while they're in there, we also ask them to enter into 12-step programs like Alcoholics Anonymous or Narcotics Anonymous and attend those at least 3 times a week. We have lots of data for many, many years into treatment that beyond treatment have very high relapse rates. So, we use a model of care here that very much incorporates a 12-step model. So,
Gotcha.
Yeah. And then all of our other medications, our medication-assisted therapy program, and Dr. Douglas and Dr. Kimball will talk more extensively about the medications. But they are tremendous help in allowing individuals to establish sobriety and benefit from treatment.
Gotcha. That's super helpful. Just kind of as a foundational overview of the way it operates at the clinic. You mentioned Dr. Douglas and Kimball. They're going to talk about the medication side of things. I wanted to ask you, if someone was seeking treatment for a substance use disorder, other than medications, what types of services or offerings are there? What could they expect when they're going to treatment and looking at things besides medication?
Sure. Well, based upon that evaluation, we're often looking at whether or not someone needs to be detoxified, to be admitted to an inpatient setting for detox. And very often we've already clarified whether or not that's necessary just in our phone conversation. But when they come in, we're looking at whether, the severity of their symptoms, the level of support that they have at home or in the community. And if they need a higher level of care than what we do here, we often refer them to an inpatient setting. And there are some outstanding treatment programs not too far away from here. We often refer to a facility in Greensboro called Fellowship Hall for inpatient care. We collaborate very often with other facilities. A lot of individuals that go to inpatient care step down to an intensive outpatient level to continue their treatment. And we also, as a part of our treatment programs, the model we use, we often look at, we call it the whole person model, where we're looking at mental and emotional and social and spiritual sobriety. So many individuals think that if they simply quit using the chemical, then their problem has gone away. Or that then what we often find is that when individuals stop using their chemicals, they're often left without the tool that they use to try to deal with things in their lives. So we also do some specialty programming here. We have some women's clinics.
Okay.
And that's one of the big things. Many of our women come in with different issues or more severe issues. A lot of women for years have gotten in treatment at a lot later stage in their addiction process. So we try to focus on their specialty needs. So when we're doing this, we're looking beyond just medications. The medications simply help us initiate that process of sobriety and decrease cravings or the obsessive thought processes of wanting to use. And it also does away with the physical withdrawal processes. And,
Gotcha.
We can deal with that stuff. We can then begin to work on those other areas, mental, emotional, social, and spiritual aspects.
Gotcha. Well, I'm really glad you touched on that. Kind of the whole person approach with, the substance abuse and abusing these chemicals, whichever, might be the chemical of choice, obviously has adverse effects on your physical body, mental and emotional tolls as well. So, obviously one of the goals is to stop, using this substance that is harming them. But you all go behind that and kind of take a deep dive into some underlying issues that might be there to help, when they do stop using the substance, it needs to be more sustainable and hopefully last long term than just, hey, stop using, drugs and alcohol. Okay, see you later. But you all take a deeper dive and find maybe some underlying issues that can help the person long term, right?
Right, we do. We look at addiction as a disease process of the brain. I like doing a lot of the discussion about the neurobiology of addiction and how those changes that occur in the brain are permanent changes. It's that most people have heard that thought, well, once an alcoholic, always an alcoholic, and how does that really make sense if a person stops drinking? And when we're looking at some of the changes at the level of the neurons in the brain and how even though the brain may start functioning better and looking different when we're doing PET imaging, what happens is if they go back to using those, the brain almost instantly reverts back to being like it was when they were using in the past.
Wow.
Yeah. So we begin that whole process of educating people. One of the biggest fallacies that most people have is, and most people have had someone say this to them, if you just had enough willpower, you can stop. And I almost jokingly talk about, willpower is the arch nemesis of recovery. I always joke that alcoholics and addicts, they absolutely do not suffer from a lack of willpower. They actually have an overabundance of that, because it'd be like trying to use willpower, like a diabetic trying to use willpower to make their pancreas start working again.
Yeah, interesting.
Yeah. So, just the process of educating and helping people through some of these myths, and then some of that denial processes, we can begin to talk about all those other things, the problems going on in a marriage, the problems, coping with emotional processes, resentments, anger, fear, and those are all just part of the processes of being in a treatment program. And we just find that most people There's some data, I can't point it out specifically, but in the treatment industry for years, it was that people who wake up one morning and try to stop using, about a year later, only 1% of those people are still sober. But for people who get good treatment, when they finish treatment, if they do not do anything beyond that, only about 10% of those people are sober a year later. But for people who get good treatment and continue to engage in ongoing recovery, like going to 12-step meetings, coming here to aftercare, they do that about 3 times a week during their first year of sobriety. At the end of the year, about half of those people are still sober.
Oh, wow.
That's a tremendous statistical difference.
Sure.
It's a process. People struggle, but we understand that it's a process toward recovery. It's not just something that happens one day.
Yeah, that's great information. I want to bring Dr. Douglas into the conversation now. Dr. Douglas, we've been listening to Dean, kind of give us an overview, and there's some, processes by which you all go and take a holistic, whole person approach. Obviously, one of the tools in the toolbox for y'all is medication and medication treatment. And one specific, issue that we've been facing here in North Carolina and nationwide that we hear a lot about in the media, of course, is the opioid use and just the staggering statistics around opioids. To just kind of dive into that specific issue for a minute, what are some of the medication treatments that you all are seeing that have been helping patients surrounding this disorder with opioids?
Absolutely. And, to kind of lead off onto this question as well, in our clinic, the vast majority of our patients in our medication-assisted treatment program, our MAT program, do have opioid use disorder. But we do treat patients with all types of use disorders. It's important to not have a bias of what somebody is going to look like or their history of opioid use disorder. Sometimes I think people assume that it's going to be somebody who's injecting with opiates such as heroin. That's not what the vast majority of our patients are. A lot of patients come to opioid use disorder after prescribed opioids for pain. So, when somebody comes in, doing that assessment also helps us to determine what medications they might. And when treating opioid use disorder, besides the 3 main medicines we use, which are methadone, naltrexone, and buprenorphine, you also have to think of medications that are going to treat the anxiety and the depression aspect. I think when people are in active use, they don't realize that there's typically a depression that happens after active use. And so we need to make sure to fully support patients during those times with other medications as well. So on those 3 medicines that I mentioned, methadone, naltrexone, and buprenorphine, they have very different mechanisms of action. Methadone, for instance, is one that probably most people have heard about.
Yes.
It's been around for a long time, these methadone clinics. Those are daily dosing clinics, typically. They're what we call a full agonist. In other words, they're going to fully act on that opioid receptor. You have to be careful with these medications that patients aren't also using other illicit substances at the same time, because that can cause what we call respiratory suppression. Where patients can put themselves at risk of dying because they stop breathing. That's the danger of that opioid receptor. The next one, that naltrexone medicine, there's an oral option for naltrexone and there's a long-acting injectable. I'm seeing more patients look for long-acting injectable options. They feel that it kind of helps them to not think about their medications every day. It's a once-a-month injection. That naltrexone is the opposite of methadone. So the naltrexone is actually going to block that opioid receptor. So it's a much different approach. So it blocks cravings and it also blocks that opioid receptor. So if somebody does use an opioid, they're not going to get the same high from it. And that's how it helps people maintain their sobriety.
Interesting.
And then the last one I had mentioned, buprenorphine. The brand names that you might hear oftentimes are Suboxone or Zubzol. Those are either a tablet or a film. And for that buprenorphine, those tablet and film, they come a lot of times in what we call a combo product. So in order to make sure that people don't misuse the buprenorphine and inject it, they put the naloxone with the buprenorphine so that if it is misused and injected, the patients will go through sudden withdrawal. But if it's taken as prescribed, which is for it to dissolve under the tongue, then that naloxone does not get absorbed into the system. So it does not cause withdrawals. And that one also, besides the oral options for the buprenorphine, there's also a long-acting injectable that came out. So it's a once-a-month injection of buprenorphine.
So, how difficult or complicated is it if someone comes in and, they're seeking treatment for substance use disorders? How hard is it to start one of these medications? Is it a long ramp-up time, or, what are the constraints that you'll have to work through?
Right. That's a great question, because I think sometimes patients assume that the medicine's not working for them or that they had a reaction to the medicine, when in actuality, it's that they might not have started it the way that they needed to. For instance, we'll start off at the top again with methadone. So with methadone being what we call a full agonist, somebody does not need to go through what we call withdrawals from their substance of use before getting started on it. And it's a daily dose. You go to a methadone clinic every day. The naltrexone, because it's an antagonist, so it's the opposite of methadone. That naltrexone, you have to have fully washed out all of the opioids that are in your system. So when we discuss detoxing or withdrawing, you need to slowly come off all the opioids that are in your system.
Sure.
There's medications that we can use to help with that detox.
Okay.
And then the other one is that last one I mentioned, that buprenorphine. Well, for buprenorphine, you do need to make sure that you're in what we call withdrawals. And, there's a scale that we use, opioid. We call it COWS. So it's the opioid withdrawal scale. Once a patient is in withdrawals, taking that buprenorphine allows them to reduce the side effects of their withdrawals. It's what we call a partial agonist. And if somebody were to take the buprenorphine too early, so they haven't really gone into their full withdrawals, they might feel sick suddenly, like, oh wow, I'm having a reaction, I'm in like full-blown withdrawals right now. That's because they've taken it too early. If they were to wait just a few more hours to let those opioids fully come out of their system, then that buprenorphine is actually going to lift them up to that partial agonist level.
Okay.
And the beauty about the buprenorphine is it's not a daily dosing, so you can come in once a week, get a med check, and you can get enough medication to last you for a full week, or the long-acting injectable, in that case, a full month.
Okay. Well, I guess that leads into my next question is, are there certain, I guess each situation and each medication management situation is different, but is there a length of time that someone needs to stay on these medications? It's probably not quite, the same dosage as my 10-day antibiotics I'm on. Y'all probably have a more complicated plan for persons over the long run, correct?
That's correct. So with these medications, there is not a set time limit that somebody's going to stay on medication for a use disorder, and that's regardless of the use disorder.
Okay.
They can stay on it as long as they need to. One of the risk of patients coming off too early is if they haven't really met those therapy goals. So if they haven't addressed their friends and family, their community environment, where they have a safe way to socialize without re-exposing themselves to substances, making sure that, so we talk about the people, places, and things. They got to change their lifestyle.
Yeah.
And that's going to take time, and it takes a different amount of time for everyone. So after they address those psychological needs, then we can start talking about, well, maybe we can lower them. But as far as setting a timeline, it's very individual. Patients that have been on this medication for a long time. Some patients have chronic pain, and for them, they're not necessarily looking at coming off of, for instance, buprenorphine, because we do use buprenorphine to also treat that pain as well as opioid use disorder. So they may, need to be on it for the rest of their lives. But therapy is the, one of the other things I can definitely say about the medications, with people consider, is the medicine working well for them? On the oral medicine, such as buprenorphine, I'd mentioned it has to be absorbed. It has to be absorbed sublingually, so under the tongue. Sometimes patients don't realize that, and they might be swallowing the pill, kind of chewing up the film and trying to swallow that in some way. And so if they're not taking it properly, that can cause them to not feel the full benefit. Another thing that psychiatrists will often recommend is not to smoke before using the sublingual, because smoking actually constricts those blood vessels. It can get a lot more difficult for them. So, little things like that. If somebody doesn't feel like they're getting the full benefit of the medication, then definitely they need to talk to their physician.
Gotcha. So, obviously when physicians or providers are talking with patients about medications, one thing they often, if not all the time, bring up are side effects or maybe some other risk with taking medications. Obviously for the patient, there has been a risk, adverse situation with the substance use disorder that they're facing, whatever the substance is. It's having a negative effect on their body and their mind. So you transition them to managed prescription medication, and you guys go over those risks with the patients as well. Do you just want to highlight some of the more popular risks, if you will, that you often get into conversations about at your clinic?
Sure. Well, so for instance, the ones that methadone and buprenorphine, those two. Sometimes patients will say that they might be too sedated on those medications, in particular the methadone, since it is a full agonist. And so for that one, it might just be that the dose needs to be adjusted. Buprenorphine, I've had, very rare instances of patients having like swelling in their feet. And that's something that we might need to do dose adjustments for the buprenorphine. Headaches occasionally happen, and probably the most common side effect would be constipation, and that's because of the fact it does work on those opioid receptors. So any constipation we can also manage either by lowering the dose or by giving medications for that. Some of the risks, though, I think that are most concerning, that we warn our patients about, is not to mix either the methadone or the buprenorphine with benzodiazepines. And that benzodiazepines, patients might know of as either clonazepam or Xanax, Ativan, that entire class of medication. You wouldn't want to mix them because both these, the methadone and the buprenorphine and the benzos, work on that same, what we call a mu receptor. That's what gives you your respiratory drive. So when we're worried about overdose, we're worried that somebody's going to have medications acting on that mu receptor and cause them to have respiratory suppression, which means their body's not going to desire to breathe, and that's when they can die. So we want them to absolutely watch what medicines they're mixing with these agonists, the methadone and the buprenorphine. Another risk that a lot of times people don't think about is if they're on any one of these three medications and they're trying to override the protective factor of these medicines by taking heroin or any other type of opioid with it, they're going to have to use a lot more of that opioid to overcome the benefit of these medications. And it might make them think that they're able to handle a higher dose of opioid, when in fact they're not. Once the methadone and the buprenorphine or the naltrexone comes out of their system, if they try to use that same level of opioid, that put them at risk of an overdose. So that's one of those that, a lot of people don't realize how they kind of set themselves up for overdose even after they finish the program.
Yeah, that's a great point. I wish we had, another hour to talk about some of the success stories that y'all have seen come to your clinic, and maybe we'll have y'all back on at a later date and we can talk more about that side of things. But I do want to bring Dr. Kimball into the conversation. Dr. Kimball, thanks for being patient with us. I do want to transition to talk a little bit about a substance that might be in more homes than maybe some others with alcohol. You can buy that at the grocery store if you're of legal age, and there's or the ABC store, and that seems to be maybe more mainstream than some of the other, quote unquote hard narcotics that other people might be facing challenges with. But it still causes issues for several people. And I'm sure y'all can attest to that. We're at home now, we're social distancing, we're not driving that much anymore. People maybe seen a funny meme on social media about, drinking wine or, day drinking, but it can definitely have adverse effects on your mind and your body, if used in an abusive way. So, what's wrong with drinking a few drinks every day while I'm at home if I'm not going out that much anymore?
Well, the National Institute on Alcohol Abuse and Alcoholism has basically said that the maximum number of drinks per day for a woman is 1 drink per day and 2 drinks per day for a man. And so basically that's 7 drinks a week for a woman and 14 drinks for a man. And really anything more than that is really considered to be harmful drinking. Mm-hmm. And so I think one of the things people don't realize is that alcohol definitely has effects, both short and long term, on almost every single organ in your body, and that the risk of damage to health increases with each drink of alcohol consumed. And especially in this pandemic that we're experiencing, alcohol use, and especially even in heavier use, weakens the immune system and thus can reduce our ability to cope with this infectious disease.
Yeah.
And as you said earlier, alcohol alters your thoughts, your judgment, your thinking, your decision making, and your behavior. Mm-hmm. If someone is pregnant or thinking of becoming pregnant, it poses a risk to the unborn child. And alcohol certainly increases the risk of any interpersonal violence that someone has, and it can increase the risk of falls. And if someone were to develop a COVID-19, the use can also increase the risk of someone developing complications from that disease process.
That's very interesting, Dr. Kimball. Maybe to back up one step, just to help me understand, when I am drinking alcohol, and what is the alcohol doing to my body that is giving me that feeling that alcohol does? What's happening inside my body that alcohol is affecting it that way?
Well, I mean, alcohol is a relaxant, and
okay,
and it's certainly something that has been used for millennia to help with a variety of situations, and certainly can help with anxiety. Part of the problem is that it's a double-edged sword. So the more people drink, the more they want to continue drinking. Our body gets used to the amount that we do drink, and so as time goes on, the amount that may have been beneficial to us at one time tends not to be as effective in the long term, and then people might need more and more alcohol to get the same effect that they help with them.
Gotcha. So, speaking of COVID-19, people may be seeing on the news or on social media about a few distilleries switching from making their traditional alcohol to drink to disinfectant alcohol, like hand sanitizer. So that's been interesting to see. But going back to the actual just drinking alcohol, whether it be, whatever it is, tequila, gin, vodka, wine, beer, does that in any way help if I'm drinking alcohol? Is that helping me to prevent or quelch this virus, COVID-19, at all?
That's a good question. And there's absolutely no evidence that alcohol can either prevent the COVID-19 virus or treat the COVID-19 virus. And just because disinfectants have topical alcohol in them, the amount of alcohol in vodka or gin is not as concentrated as that in your typical disinfectant. And so, as I said, there's absolutely no evidence that it can prevent and treat it. And as I mentioned earlier, it could make a whole bunch of other things potentially worse for a person.
Yeah. And I guess this would probably be a good time to throw in the disclaimer or PSA that people should not consume hand sanitizing or disinfectant alcohol as well if they fear that they might have come in contact with COVID-19. They should not consume hand sanitizer or anything else like that, right?
Absolutely. Please do not drink hand sanitizer. And along those same lines, there are other products that have alcohol in them. For example, isopropyl alcohol or rubbing alcohol.
Yeah.
I've seen patients in the hospital, if they didn't have their vodka or gin, consume that, and that tends to be really bad and can cause kidney damage and a whole bunch of other problems for the body.
Man, well, thank you for helping just to reiterate that point. It's people. We're at a stay-at-home order right now. We've been told to alter our lives in noticeable ways. We maybe have to work from home, or maybe some of us have been furloughed or laid off, and we don't have our job right now. And we're having, some people are more isolated than others. What are some options people can do if they need to seek medical advice during this time? If maybe they think they have been abusing alcohol or they're tempted to, what would you say to them as far as options available to them?
Well, there's several options, and our clinic here on 791 Jonestown Road remains open. And even if someone is concerned about leaving their house, we are more than willing to do a phone visit with someone, or potentially do a video type of visit, similar to Skype or FaceTime with someone, to really help with their need. And as my colleague Dean mentioned earlier, we could really help to see, do they need an intensive outpatient program? Do they need any to have a medical detoxification? It can provide other resources as well too, including treatment of any comorbid mood or anxiety disorder that the person may have.
Gotcha. That's very helpful, Dr. Kimball. You mentioned detox right there. This should be a good follow-up. What advice do you have for detox if maybe someone has faced a substance use disorder situation in their lives, or they know someone that has? Some people are like, oh, I got this on my own. I don't necessarily need to go see a doctor or go to the doctor's office. I can just quit cold turkey and I can do this. Or maybe they don't think that. Maybe they're like, yeah, I definitely need help to go through a detox. Can you talk to us a little bit about the detox process and why having medical providers involved in that is very important?
Sure. So when patients have an addiction, addiction is a medical disease. Addiction is not a disease of willpower or some psychosocial failing. And so because addiction is a medical disease, really it's the medical professionals who really can help with that person and help them to best be in treatment. And as my colleague Dean said earlier, patients decided, yeah, I can do it on my own, and I'll just white knuckle it or whatever. Very few of those patients actually are successful.
Yeah.
And so, that we are here for people who, if they're trying to get off their substance and need detox, we're here for people to talk about what potential options are available. If someone has had a history of delirium tremens or DTs, it's really unsafe for that person to try to detox at home, and that person would probably need to go to an inpatient facility to help. But in other cases, we can provide options for that person, including the potential outpatient detoxification.
Gotcha. That's very helpful, Dr. Kimball. I appreciate that, and appreciate all of y'all's great information and guidance. We're getting ready to wrap up this episode talking about substance use disorders and specifically options for treatment during this time of coronavirus, where our lives have been altered in major ways, possibly, and there's increased anxiety and stressors in our lives, and possibly, we're having to deal with kids at home or elderly parents, perhaps, where we can't go see them. That's a lot for some people. What resources? I guess I just want to close with this question. And Dean, we can start off with you, and then Dr. Kimball and Douglas, jump in, please. But what resources would y'all offer, just as a closing comment, for people if they would like some more information about treatment, or they know someone, a family member or a friend that they think could benefit from this information? What resources are out there in the community?
Well, certainly we're continuing to provide all the services we've previously provided. We're just, as my colleague Dr. Kimball mentioned, we're doing things virtually or doing phone visits. Mm-hmm. Most other facilities or programs within the greater Winston-Salem area continue to provide their same services. They're just using those other methods to get that message out.
Okay.
So there's also Baymark Recovery Services. They're still doing all of their services. And there's also the support groups that are all voluntary that are going on, such as Alcoholics Anonymous, Narcotics Anonymous, or Drug Addicts Anonymous. They're all having virtual meetings.
Okay.
So one of the websites for all of the local 12-step meetings for AA, anyway, their website is wp.nwpi.net.
Okay.
And individuals can go there and enter into a 12-step meeting. And that's been their response. It's been very helpful. It's been a tremendous response to people who are at home and just can't get out.
Dr. Douglas or Dr. Kimball, any closing comments along those lines?
Well, I think, you had mentioned the stress that people go through with being away from family members and loved ones right now, maybe in the sense of isolation and boredom that they're experiencing at home. I think the advice that I would recommend is really try to stay on a schedule. It can be very tempting to just sit in front of the TV and watch the news and just build that anxiety. Instead, try to be productive. There's a lot of YouTube options. Mm-hmm. I've challenged patients to try to find a different workout video. Maybe they've never done Pilates before. Well, you know what? Now's the perfect time to try Pilates.
Yeah.
You like it. There's fantastic videos out there now. And many of these subscriptions that you would have had to pay for before, companies are offering them for free right now during the COVID pandemic. And, the groups are a great way, the online groups are a great way to remain socialized. Call family and friends and try to get outside and get some fresh air. Just, being in a box 24/7 is not healthy. And so just get outside, walk around a little bit, stretch.
Yeah, and I guess I'd echo some of those comments. I think all of us have said at one time in our lives, I wish I had more time. Well, guess what? Now we all have more time. And so I think, what are some productive things that you could do with that time that you've been neglecting or putting off for that whole time? And I guess the other piece of advice is be patient. We're going to get through this, and we're going to come out stronger in the end.
Well, that is a great closing comment, Dr. Kimball. I appreciate it. My three guests today, Dean Melton, Dr. Heather Douglas, Dr. James Kimball. Great information. I appreciate you all taking time to talk with us today on this Best Health podcast. And to all our listeners out there, appreciate you all listening. Feel free to share this with anyone that you might think could be benefit, and maybe on your social media as well. If you see the link out there on where you get your podcast or on the Wake Forest Baptist Health social media. Thank you all so much for joining us today. I hope you all stay healthy and well.
Thank you.
Thank you.
Yep. And to all our podcast listeners out there, until we chat again, please be well.
Thanks for listening to this episode of the Best Health Podcast, brought to you by Wake Forest Baptist Health. For more wellness info, check out wakehealth.edu/besthealth and follow us on social media. Wake Forest Baptist Health. Care for life.